So I wanted to talk a little bit also about VEMPs. That's on the list, and we have, every year we have more and more clinics that want to add VEMP to the testing that they're doing. And there are basically two types of VEMPs. There's a cervical VEMP and an ocular VEMP. The cervical VEMP is the more commonly measured one. And people have been interested in this, say, for the last 6 or 7 years, and every year we have more and more clinics that are adding this to the routine tests that they do on balanced patients. And in fact, recently, some of the manufacturers have been able to add a EMG monitor to the equipment. Because one thing about the cervical VEMP is it is an inhibitory test. Not an excitatory test, but an inhibitory test. So the response actually inhibits a muscle contraction. The patient actually has to contract their sternocleidomastoid muscle here and hold that contraction during the time of the test, because the response is an actual attenuation of that contraction. And that's why that's so important. And any type of pathology shows up as an asymmetry between left and right. And so if the patient does a better job contracting the left side and a poorer job on the right side, then you can have a false positive that's just due to the patient's contraction of the sternocleidomastoid muscle. And we tried all kinds of different ways to do it. Oh, have the patient turn their head like this. Okay, that's fine, but what if they do it on the other side and they do better when they're facing right than they do left? And so Neil Shepard told me one time, take a blood pressure cuff and have it on the patient's hand and have him push his face against his hand and actually read the meter, and the meter would have to be at 30 or 40 or something like that in order for the patient to know he's applying enough pressure. So we've tried all of that, and none of that has really worked. There were too many false positives until we came up with the idea of laying the patient down supine, having him lift his head so that he can actually see his feet from heel to toe, and then turn and look at his shoulder. So this gives you very much of a maximal contraction of the sternocleidomastoid muscle, and all of our users who do that regularly are successful with it, except for patients that can't do that test, because you really have to hold it for about 15 seconds. So we have some people that just can't do that, and the alternative that we give them most of the time is to adjust the exam table to the 30-degree position that you would do calorics in, and let the patient do the same thing with the back of the exam table raised up to 30 degrees, which is a little easier on the stomach muscle. And most of the patients can do that, and it gives you close to a maximal contraction, and we've been having good results with that. But now some of the equipment has a new feature, like this. This is a measurement of the EMG, all right? So the contraction of the sternocleidomastoid muscle is actually recorded, and you can make sure that the patient does the same amount of, gives the same amount of effort for right and left. In fact, I've used that and tried the different techniques that we've used over the years, and yes, it's very easy to get it wrong when you're just turning the patient's head, like we used to do. But when you have them lying supine, raise their head up so they can see their feet, and then turn and look at their shoulder, then it's almost automatically equal. I didn't know that it was equal. I assumed it was equal before, but now that we have the monitor, I know that it's equal. In fact, there's an external monitor that you can put on these systems that actually turns green when the patient does it the correct amount and is red when they don't do it the correct amount. So they can actually watch that while they're doing it, and they'll know that they're contracting the muscle properly. So that's an excellent thing in this system. But why people want to do the CVEMP and the OVEMP is because it adds to the comprehensive testing of the vestibular system. The V-hit test was good for us because we got all 6 semicircular canals, 3 on each side. But what about the rest of the vestibular system? Well, if you include an OVEMP and a C-VEMP, you've got it. Because where does this C-VEMP, the cervical VEMP, come from? Well, it actually comes from the sacula, and it's mediated by the inferior sacula, and it's mediated by the inferior vestibular nerve. And the OVEMP originates in the utricle, and it's mediated by the superior vestibular nerve. And so once you've added a C-VEMP and an OVEMP to the V-hit testing, you're pretty comprehensive. If there's vestibular pathology, you'd be pretty comprehensive in being able to find it. And you haven't even done your VNG test yet. So what's some great things about VEMP? Another great thing about a VEMP test, it only takes 15 seconds. That's one good thing. Another good thing is it's not affected by sensorineural hearing loss, because it really has nothing to do with the cochlea. It's not a cochlear response, right? It's not mediated by the cochlea afferents. So what are we actually doing? Why are we doing this on a auditory evoked potential system? Well, we're using we're using an auditory stimulus, actually, in the case of a C-VEMP, to punch the saccule. I'm actually using that to punch the saccule. So I want to use whatever signal I have, whatever auditory stimulus I have that's going to give me the best bang for the buck here, right? Because that's what I'm actually doing. As I said before, the C-VEMP is inhibitory. That's why that patient has to contract that muscle. Everything else that we measure, ABR, ECOG, OVEMP, all these things, they are excitatory responses. This is the only thing we do that's actually inhibitory. And that's what makes it interesting. Another little problem that we have with this test is that there's plenty of pathologies that can make it abnormal. It could be abnormal if there's a vestibular neurosis, an acoustic neuroma, labyrinthitis, a brainstem stroke. Conductive hearing loss will give you a false positive. Meniere's disease, and superior canal dehiscence. That's a big one, because this is a classic test for that. And so the reason I put this slide up and the monkey is scratching his head is to emphasize that any test by itself, just isolated by itself, won't give you the comprehensive information that you're trying to have. It really needs to be part of a battery of tests. And once you have the complete battery of tests, then you've got everything, and you can differentiate one type of pathology from another. So you wouldn't want your doctors to order a C-VEMP, for example, in isolation and no other testing involved, because it certainly would need a much more inclusive workup. But here's a good slide to have, and this is why I wanted to give you a handout, and you can get these from the ALA organization. You can get the actual PowerPoint if you wanted it. But this is a good slide to have because it kind of gives you the different pathologies that can make a VEMP test abnormal and how it is actually abnormal with that particular, like labyrinthitis here. And in most of the tests, the VEMP response will be either absent or significantly reduced on the side that's affected by the pathology. But there are some cases, like superior canal dehiscence, where the VEMP response is actually enhanced on that side. You got a giant one, you go, wow. In fact, you find the threshold of it to determine that it is, in fact, an enhanced response on that side. But that's unique to superior canal dehiscence. Most of the pathologies will cause the response to be absent or significantly reduced. So here's the electrode montage that was recommended in all of the literature. So it's very simple. You take the electrodes that you would normally have behind the ear when you did an ABR and move them to the SCM, I'll call it now because it's easy to pronounce. You move it to the SCM muscle. And what I tell users to do is to typically put it in the middle of the upper third, right smack in the middle of the upper third. You could divide this in thirds, lower third, middle third, upper third, right in the middle of the upper third, right smack on that muscle as they turn their head and try to look at their shoulder. And the ground we were putting right here, and I always complained about that. I didn't want to put it there on guys' hair and everything. And on women, I didn't want to go there with that. And so I was wishing we could put it somewhere else. And then I was at a conference, and Dave Sapala was talking. He's a statistician. He's with the Mayo Clinic. And he said he felt the same way I did about putting that electrode here. And so he said, I'm going to do a research project. I'm going to just put it on the forehead and see if it makes any difference clinically. And it didn't. And I said, David, that's the best thing I ever heard, because now from now on, I'll put it on the forehead. It'll be so much easier. So that's what we do. So just 3 electrodes like that. And then here's what we have the patient do. They're lying supine, and then they raise their head so they can see their feet, and then they just turn away from the stimulus and look at their shoulder. We actually tell them to look at their shoulder, and they have to hold that position for about the 15 seconds that it takes to do this test. If they can't actually do that, then I just raise the back of the chair to the 3rd degree position that we would normally do calorics in and let them do it that way. And if you have the VEMP monitor, then you can have them just watch that. Well, how do you do this? We use a tone burst because we found it gives you the highest amplitude and the lowest frequency that we can get a lot of intensity. You want to do it at least at 100 dB. So on some equipment you can get 100 dB or 105. Remember, we're just trying to punch the sacral. We really don't care to be frequency specific. So 500 hertz, if it'll go loud enough. On some equipment it'll only go to 80 dB, and that's not enough. So then I use 750, as long as I can get at least 100 dB out of it. I like 105 if I can get that. But the response diminishes as you turn down the intensity of the stimulus. And then when you get to 90 or 95 dB, that's it. You've arrived at the threshold. You go any lower and it's gone. Unless it's superior canal dehiscence, and then you'll find an abnormally low threshold, something around 65 or 70, and we'll have confirmed that it is superior canal dehiscence. Okay? All right. So the protocols that we use is a tone burst, 500 or 750, whichever one will go louder. And I just make it a condensation click. I just do it at a low rate, 5 to 8 per second. No Bayesian weighting or anything like that. I'm trying to punch the sacula, so we got a better result just by using linear. No Bayesian. I'm sorry, I'm not talking about Bayesian weighting. No Blackman filter. No Blackman filter. Just linear filters on the tone burst. And then intensity, something over 100 dB. And you can have a rise time of 2 milliseconds. That's fine. That's the same thing we do for most tone bursts. The gain is much lower. This is going to be a bigger response than you're used to. So you can't have the gain of the system at 100,000 or 150,000 like you normally would. You have to turn it way down to like 100,000. No artifact rejections. Just turn that off. No such thing. Filters are about 10 hertz to 1,000 hertz, or even 10 hertz to 500 hertz. This is a low frequency response. I collect it in a 100 millisecond window, and I do about 120 tone bursts, 200 at the maximum, right? And do it twice to make sure it replicates. And then you notice that these are way off the scale, and you've got to turn the scaling down until it's actually fits on the screen. But you can have that slide just so you have the protocol, and on most equipment you can put that protocol in. And there's a positive and a negative peak. The first peak is going to occur somewhere between 12 and 19 milliseconds. And then the second peak is going to occur between 20 and 28 milliseconds. This is from the Mayo Clinic at David Zapala. And it'll have an amplitude typically around 180 microvolts. Now, that's a big, big response, 180 microvolts. An ABR at high intensity on an adult wave 5 is about a half a microvolt. Now, we're talking about 180 microvolts. I remember I was showing the students at Auburn this one time. I forget what year it was. And there were like 8 or 9 students in the class, and they were all young ladies. And one young lady, her neck was outstanding, and when she turned her head, that sternocleidomastoid muscle just popped right out. And I said, what do you do? And she said, I'm in the ROTC, sir. And every morning we get up and we do 5 miles of running, we do 1,000 push-ups, and then we're ready for the clinic. I go, oh boy, you're going to be the test patient in this. And her CVEMP was off the scale. It was like 400, not 180, very typical for an adult, but like 400. And you would think, if you looked at it at first, that you had superior canal dehiscence on that side, but the other side was the same. You would always have an asymmetry in abnormal cases. It was just that she had such a prominent sternocleidomastoid muscle. Anyway, that was interesting. So it's going to look like this. This is on a biologic ABR unit. There's the first peak, and depending on how you have the electrodes, this could be reversed. So if you see it in the literature that looks like this is upside down, that's fine. Doesn't matter what you do. Well, as long as you mark this peak and you mark that peak, and you're going to find the amplitude of it and compare the amplitude of the right to the amplitude of the left. You see these were run twice, and I got the same thing twice, so I'm pretty confident I've got a nice muscle contraction. And you'd have to have a difference in amplitude ratio of more than 0.35 in order for this to be significant, right? So what's important about the CVEMP? Well, stimulus level, that you got it loud enough, and I say at least 100 dB. Stimulus frequency, that you don't go over 750. It's either done at 500 or 750. Make sure they're contracting that muscle enough, and equally for right and left. And the technique that we explained is the best one for that. And make sure that you don't have a false positive because you didn't put the electrodes equally, right? So they have to be symmetrical. You can't have one up here and one down here. If you did that, then you'd have a false positive as well. But this is really all you have to do. Once you get used to looking at these 4 things, you'll avoid having a false positive. And if you've got the EMG monitor, it even helps more. So I have our users be sure that the response is present and that it is repeatable, that they can do it twice and get basically the same thing. And look at it and see if the amplitudes are equal, because if they're within 50% of each other, they're fine. However, if they're not, or if it looks like there's a 50% difference or more, then we have them calculate the asymmetry ratio. And an asymmetry ratio of greater than 0.35 is considered abnormal. And when you say that, asymmetry ratio, audiologists go, what? How do you do that? Well, it's pretty easy. It's simply this. It's the difference over the sum, and if you multiply it by 100, you can have it turn it into a percentage. But it's just the difference over the sum. So you take the 2 amplitudes, subtract the smaller from the larger one, get the difference, add them together, and you've got the sum. And just do the division, and you've got a number. And if it is, if it's greater than 0.35, then it's abnormal. Okay. And usually the response on the affected side is absent or reduced. Okay. And when is a CVEMP contraindicated? Well, if there's a conductive loss. Why? That makes sense. Because we're using auditory stimulus to punch the saccule, right? Well, if there's a conductive loss, then there's something that's muffling the punch. And so that's going to make it contraindicated. If the patient can't do the task, they don't have enough stomach muscle to be able to lift and turn like that, that could do it. I have some patients where you can't find their SCM on their neck, right? Are you turning your head? Look at your shoulder. That's the best instruction. And you can't even see this. You're taking a guess where it is. Well, very high possibility of a false positive on that, right? So that might be one. And then I put this last one in there. You did an ABR on the same day. A lot of clinics, this is another test that there's no CPT code for. A lot of clinics do an ABR. They do a quick ABR at 90 in order to be able to charge that ABR CPT code. But of course, if they did an ABR on the same day for some other reason, they might not be wanting to do a CVEMP also and try to charge for that twice. Okay, well, what about an OVEMP? All right, well, that's pretty easy to do. That's an excitatory response. It's not an inhibitory, so the patient doesn't have to do anything except look up. And now we are getting a response not from the saccule, but the utricle, and not from the inferior vestibular nerve, but the superior vestibular nerve. And we're recording it on one of the ocular muscles below the eye. I'll show you how you put the electrodes on in a minute. You're going to identify the same type of pathologies as you did with the CVEMP, so that's good. And you're going to use the same exact protocol, except that the gain is going to go back up to 100,000, the same gain that you would use for an ABR or an ECOG. Otherwise, it's the same thing. And you're going to get a response that's a little bit different. You got two peaks. The first one, we call it N1. That's going to occur somewhere around 10 milliseconds. P1, the positive peak, is going to occur somewhere around 14 milliseconds. And it's recorded from the contralateral eye, not the ipsilateral. So it's a little bit different than we're used to. And the same thing. The amplitude ratio is what matters, and it would have to be greater than 0.35 or 35% to be significant. How do you place the electrodes? Just like this, right? You can do it with a two-channel system or a one-channel system. With a two-channel system, you don't have to change electrodes or plug in different electrodes when you change ears. But those muscles, those are the muscles you're actually collecting this from. I get this one as close as I can to the eye, and this one as close as I can to this electrode without touching it. And then during the test, the patient is looking up. We actually give them a target on the ceiling, and they have to keep their eyes on during the test. I heard that when pediatric clinics do it, they actually hold a iPad up for them to look at, and they've got a cartoon running on the iPad. So as long as they hold their eyes there, you get a response something like this, is on a Biologic Navigator Pro. And the contralateral side is the one that you want to measure the amplitude on, peak-to-peak amplitude, and compare it with the stimulus in the other ear. All right, so that was just an overview of CVEMP and the OVEMP. And those things have been, in the last couple of years, extremely popular, and you can see why, because you're really comprehensive in your testing of the vestibular system if you add these to what you're already doing. Thanks, guys.